We'll just roll with it. I like my notes, but I really don't know how to do it. So, okay, so I'll take my mask off, thankfully. About myself, I am a physical therapist. Number one, I graduated from University of South Alabama in 2013, so I've been practicing for 7 years. I started out in an acute care and then an outpatient mix at Providence Hospital. I was there 3 years and I left there to run clinics for corporate PT. So I had worked for 3 of their clinics, and in 2017 we had a pelvic health physical therapist who was working for us, and she was leaving, and I had an entire caseload of pelvic health physical therapy patients who needed help, and an entire set of doctors who all knew that we could help them, and then all of a sudden the therapist left. So instead of going to each of those doctors and being like, sorry, I can't help your patients anymore, I decided to get on a plane and go to a course and learn how to help them. I had co-treated with her several times. She went to Europe for 2 weeks or something, and I took all her patients then, and really enjoyed the population because they have a lot of light bulb moments. Sometimes they're things they've been dealing with for their entire life and never sought treatment, or just thought it was normal and just kind of dealt with it. And then when they get in there and they're learning about themselves and about even the anatomy, and just a lot of times there's a lot of light bulb moments really quickly. So I fell in love with this population. I still continue to treat orthopedics. I am board certified in orthopedics, and it's a nice look at the pelvic floor, because the pelvic floor does not operate in itself. There's the nervous system coming out of the lumbar spine, and so that's what I wanted to share with y'all today. Just some of the complexities about it, and how you can recognize patients who might need either pelvic floor physical therapy or referral to a specialist like a urologist. So these are my objectives. Definitely an anatomy review is huge. Talking about the different types of incontinence is important to understand. Not all incontinence is created equal, and not all patients need Kegels. That will not be the only time I say that today. So understanding the pelvic floor is part of the lumbopelvic core is also important. Like, our body systems are all in operation together. Nothing operates alone. So that's a huge thing to just kind of understand. And then we will talk about Kegels and relaxation training, and then coordination training, and just kind of who to send to pelvic floor physical therapy. So this is the female and the male anatomy. Dr. Mott said I could use my stick. Let's see here. So they're very similar. So a lot of people say, or you treat males or you treat females. It is the same in a lot of aspects. So the main things to point out is it's muscular. There's membranous tissue, but there are several layers of muscle that we treat. So this is going to be your superficial layer, and this area here, a lot is going on there. I kind of equate it to like the C7 area. You have upper trap and some cervical muscles and some shoulder muscles all kind of coming together at that junction there, and that is your Grand Central Station. A lot's going on there. It can be an area of a lot of tension, and then that is also the area that tends to be torn or cut in childbirth. So even more complicated there. But you have your the same perineal body in the male too, and then you have the organs. So I just explain it to the patients. This is your pleasure center, urethra, vagina, and anus. I use my handy dandy model because they just get it when they can see it like this. So pleasure center, urethra, vagina, and rectum, and it is all entangled with these muscles. This is the superficial layer, and then sometimes I take the organs out and show them that is the deeper layer, and both can have their own separate issues or similar issues in these conditions. I might come back for that, but we'll see. So this is the first layer. The second layer is your autonomic sphincter set, is kind of what we look at. These are not under volitional control. We don't affect these that much other than kind of coming in the back door and affecting the nervous system in general with down training or just training of the nervous system. And there are fascial connections with the abdominal wall. This is huge. Your C-sections, abdominal surgeries, abdominal complaints, any prolonged issues that they're struggling with, bowels, stomach, GI, everything is so connected that can drive issues with the pelvic floor and lead to your leaking or your pain conditions. So that layer is important to kind of know what's going on there. And then your deeper layer. So levator ani muscles, pubococcygeus is just kind of one, we kind of throw a couple muscles under there. It's just kind of the sling of the anus. This is where we get into teaching patients good bowel movement posture because this pubococcygeus is on tension when the knees are below the hips in bowel movements. With these higher and higher and higher toilets, it is an epidemic of sending me patients, and sometimes all I have to do is say, just get your knees above your hips when you poop, and they're like, wow, everything is so much better in my life right now.
What's that, stool?
Squatty potty.
Bath and Body Works.
I know. They're online, Bed Bath & Beyond. They're so good at their marketing. They send pelvic health physical therapists free copies for their office. So we have them in the office. So coccygeus, iliococcygeus, if you want to know the names. I just call it layer 1. I don't even go over layer 2 with the patients too much other than them to understand there is part that's not under their control. And then layer 3 is going to be your deep stuff. Your lower abdomen is also very connected here. Innervation is important. You have mostly sacral nerves coming to pelvic floor, but it is also important to note that obturator has some L2, 3, and 4 stuff going into it too. So motor and sensory is all important as far as the feedback going up the chain. Is the bladder full? Is the bladder not? And then also coming down the chain to control bladder as well through relaxation. And then also conversely, if a patient, like one of my first questions I ask a patient who has incontinence or pelvic floor pain, what about back and hips? You know, how have your back and hips been lately? And they'll have a story. Oh, I tore my hip a couple months ago, and that's really when my pain, you know, I have pain there, but then that's really where my other problems started as well. So it is all very connected. Piriformis, I'll talk about this later actually. You get into the skin level innervations as well, L1. So if a patient's feeling lower abdomen pain, it could be an issue happening up in their spine as high as L1. Same thing with genitofemoral L1 and 2. And then I love iliohypogastric T12 and L1. And you get into a lot of the autonomic nervous system in the thoracic spine, and the thoracic spine is huge in pelvic floor physical therapy. Not necessarily for your incontinence conditions, but definitely for your overactivity conditions. A lot of times we see this thoracic stiffness that's just like tightened down, doesn't move, gets no neural gliding of the autonomic nervous system. And just to teach them to open that up can be very helpful to what's going on down there and improve the connection from the brain to the pelvic floor. So obviously the autonomics play a huge point in it, and I can't say a pelvic floor physical therapy can fix everything because some of it is not under volitional control, some of it is reflexive. Do you have a question? Okay.
Actually, well, I do. It's not for you. It's for, so, as everybody knows here, I'm an MD, which stands for musculoskeletally deficient. I got it.
I love it.
So, DOs here, I mean, is this stuff that you learn about? Oh, yeah. Mm-hmm. Okay.
It is much easier to market to a DO than an MD. Like, I don't even have to go into the nitty gritty. I can just say, I do pelvic floor physical therapy, and they're like, oh,
watch out.
You just say voodoo.
Literally, I have my patients.
There's O&M for that too.
Okay.
So watch out.
Oh, I love the MD comment. So dural tension is huge in this. I work with a lot of new moms. That's kind of my target population. And a mom who gets an epidural is going to have some dural tension where that adhesion was made to the dura. And they might deal with long-term pelvic floor stuff because of the vaginal birth, but we also want to look at their nerve gliding and their mobility of the nerves all the way up and down the chain. Definitely slump test those patients and see what is going on there. Don't think I had any more points here. Does anyone have any questions about like bladder full, signal goes up, signal comes down, detrusor contracts? So that makes this a little difficulty because it's not always just, okay, do your Kegels, that'll fix everything, because the Kegel can't necessarily turn off the detrusor contraction in your overactive bladder conditions and stuff like that. But there are breathing mechanisms and retraining and self-talk that can actually turn off that loop too, that we can kind of get in there. Okay, so I want to see what y'all's understanding of this is. So hopefully everyone knows there are several types of incontinence, and we kind of break it into stress urinary incontinence and urge urinary incontinence, and they are treated very, very differently. So let's talk about some of the causes of stress urinary incontinence. Leaking of urine, usually small amounts, during an activity that places stress on the bladder. Coughing, sneezing, picking something up. What's the cause of that? What's going on?
Weakened pelvic floor.
Weakened pelvic floor is number one answer. That is correct. What else? Childbirth. So lengthened pelvic floor and weakened, we kind of put those together.
What about like overflow, like urinary retention or something? Could that lead to?
So that is an issue with the mechanism of the detrusor being able to contract and activate and empty the bladder completely. I do kind of have a little bit to touch on that later. That is those things that we've got to catch before we send them to pelvic floor physical therapy, because if they're leaking because they're overflowing, that is a much different problem than if they're leaking because, so we look for hesitancy of stream, interrupted stream, those kind of things are indicators of somebody who's having retention, and that needs more testing with the urologist. A point for the stress urinary incontinence I wanted to make was poor breathing mechanics. So pelvic floor, we'll talk about the pelvic floor as a core, the whole cylinder, but if somebody goes to cough or sneeze, or if they go to lift something, if they Valsalva, then they may lose urine just simply because they're putting so much pressure down. So the diaphragm and the pelvic floor are a team, and we can't treat just the pelvic floor without also addressing the patient's habits around the breathing and their breath holding, their Valsalva, that kind of thing as well. I wish I had my notes because there was definitely a third one.
The weakening of the sphincter or something?
I kind of put all the muscle weakness together usually, but we'll talk about a few more things in urge. Okay, so what are causes of urge urinary incontinence?
Bladder spasm.
Okay, very good. So a detrusor spasm, where that feedback loop is telling the brain that the bladder is full, I need to empty now, and it may not be full. So I usually group that one with poor bladder habits. So if someone is frequently emptying just in case, maybe they have a little bit of stress urinary incontinence and they go to the bathroom because they're about to leave the house, or they go to the bathroom because they are about to go on a trip and they might need to go, and then they take 10 more minutes to pack the car and they're like, well, I better go again before I get on the road. So that can in itself lead to urge urinary incontinence, because they are telling their brain that their bladder is full well before the bladder is ever full. Any other ideas?
Is that why? Sorry, this is kind of. No, I was like going back to that topic. Is that why would CBT help? Behavioral therapy when it comes to that?
So we dabble a little bit in that as far as just teaching them mind over matter, positive self-talk, those kind of things. Delay strategies is a big one that we teach. Just learning themselves, like to stop before you go in the bathroom and ask yourself, do I really need to pee right now? No. maybe not. But it gets really complicated in somebody who has an emotional connection with wetting themselves previously because of some other issue. Urge urinary incontinence can also be caused by a tight pelvic floor. So a tight pelvic floor puts pressure on the urethra, and we actually usually try to teach patients to differentiate between a urethral urge and a bladder urge when they sense the need to go to the bathroom. So are they doing an activity that is stressful to them or going through a stressful time and they're literally just holding everything so tight down there that they're putting pressure on the urethra and the urethra is saying, hey, I need to go empty. Or, are they feeling the bladder expand into the pelvic cavity and actually needing to go urinate? So that's the third point, is stress. So ask your patients. I have a whole list of questions to ask. Ask your patients about their stress level. It's like, is there been a change in your stress level? They come in with incontinence. You ask them, have you had babies? What's your history? Is it stress? Is it urge? You're trying to put the picture together. Ask them, has there been a recent change in your stress levels? And how are you dealing with that? And see if there's something there. Maybe they need a counselor. Maybe they need to just advice to go talk to a friend about it. Maybe they need to come tell a physical therapist about it. We tend, in the pelvic health field especially, tend to be kind of the unloaders too, where the patients don't realize the emotional connection to the bladder. So in the brain, in the homunculus, the emotional center and the pelvic floor are really closely related. They share hormones because of sexual attraction, is why that's very important. But it can also make the pelvic floor problems, their stress and their pelvic floor problems go together. If you talk to a patient who has a chronic pelvic floor problem, they know if they're having a bad day that their stress levels are high. Or if their stress levels are high, they're gonna have a bad bladder day. They're gonna have urgency and leaking, and they better wear a pad that day and that kind of thing. So I also wanted to mention mixed. So mixed is having both of these. That a pure stress urinary incontinence, not too hard to treat. You start having some urge episodes, especially strong urges with actual loss of urine. That means that internal sphincter is opening up, and even if they had a strong external sphincter with Kegels and stuff, it might not be able to hold it. There's something else going on. Functional incontinence is the loss of urine due to the inability to get to the bathroom. So you'll see this in your older adults, your declining mobility. That's important to address too. Those people need physical therapy, maybe not this type, or maybe this type and, gait training and transfer training and there's even bladder schedules for those type of people. It's not peeing just in case, but it is just making sure that they empty on a frequent schedule so that they don't get in an urge situation and wet themselves in something that, they're out with somebody and they don't want wet clothing or have to say, hey, I need to go change my diaper, somebody help me. That's still important to somebody who's wheelchair bound as well. Fecal incontinence. I didn't give it a slide here. Fecal incontinence, we definitely look at diet, we look at the stool consistency, we see what all's been done for them medically, look at fiber, that kind of thing. And then the external anal sphincter, we teach a lot longer endurance contraction for it as far as holding in stool. Sometimes 10 seconds isn't enough to make it to the bathroom. We also teach the ability to perform a pelvic floor contraction and walk at the same time because that will help them not lose stool on the way there. But that's usually a multidisciplinary look at what's going on as far as trying to get them a little more firm in their stool and see if they have any diet intolerances or something. I do see a lot of diet intolerances with that and education on an elimination diet and that kind of thing to try to see what's aggravating their tummy can be very helpful. Any questions about the difference in stress and urge?
Is it harder when they're mixed to treat?
Yes. So a mixed incontinence, as soon as it is not pure stress incontinence, you cannot go straight to Kegels. You have to go to retraining their thoughts around their urination patterns. The breathing mechanics is huge to start there. Then I usually start those people with the down training, and depending on their urge management, we'll initiate Kegels. I teach a Kegel the first day because I need to know if they can or not. Like, I need to know if the nerves are connected. And I just kind of need to know what's going on. But some people don't realize that they walk around tight all the time. So teaching a Kegel is also teaching relaxation, which is in another slide. So for y'all, these are some things you can ask to start digging deeper. I will bring your attention to, in your packet, there is the Cozine Pelvic Floor Dysfunction Screening Tool. If you don't want to ask all of these questions, you make a copy of this or hand it to them with a wet erase marker and they fill it out. And then you can see, oh, you have this, 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 and this. I don't have to ask all of these questions now. It's a great thing to scan into their chart. You can document that you evaluated all of those things, and those were the things that they had. So any changes in bowel or bladder function, you may have someone who comes to you with a bladder complaint that is also dealing with some other thing, like constipation. Maybe they've had constipation their whole life and only pooped 3 or 4 times a week, and maybe now they're down to 2 or 3, and they think that that's just life right now, and they don't think that there might be a connection to this new onset urinary leaking, but there is a connection, absolutely. The story I have that's like the biggest standout in this, like I see it all day long, like you have a patient who's coming in with urinary complaints and you ask them, in my intake forms, how many times a week do you poop? Is it soft, solid, easy to pass? No straining. And they will say, you know, I am always constipated, or I do poop 4 times a week, but it's tiny little pellets and I have to sit there for 20 minutes to get anything out. Those people's pelvic floors are under a lot of stress just to evacuate stool and waste. So they're not gonna have good bladder habits either. So leakage, pain, hesitancy, frequency, urgency. So the hesitancy is huge. Like if they really think they need to go to the bathroom and they go to the bathroom and they sit down and nothing happens, there's something going on neurologically as far as the detrussor's ability to contract at the right time. If they have to sit there and if they have to push to get urine out, if they have to, you know, really think of different ways, sit there longer, those people have something going on. Sometimes neurologically, sometimes literally, they just don't know how to relax to open the external sphincter. But those are gonna be your constipated people too. Small volumes, large volumes is huge in like starting to decide whether it's stress or urge. Do you have strong urges? And it's important to ask them if they leak with strong urges. So do you have a strong urge? You get there, you sit down, then you pee. That's not incontinence, that's different. That's a lot easier to treat than somebody whose internal sphincter is wide open even when they're not in a toileting situation. Pain with urination or bowel movements is huge. The pain can kind of guide you back to that. You know, maybe the pelvic floor is tight, putting pressure on the urethra. Obviously, real out infection, that is number 1 for y'all, for real. And treat that if there's anything in the culture. How often are you urinating? This is a good snapshot of somebody's bladder habits. 3 to 4 hours during the day, unless I kind of give patients a pass if they've had a lot of coffee or if they literally are drinking large volumes of water. A lot of people were like, well, I had a lot of water, so I had to pee twice in an hour. Well, what's a lot of water? A whole bottle. No, that should be able to be one void and not necessarily a urination and then drink your bottle and then have to go immediately again. There's something going on there. And if it's less than that 3 to 4 hours during the day, they're not drinking enough liquids, is the other inverse of that that's important to address as well. Any change of volume of urine voided? I tell patients at least 15 seconds of a light to moderate flow. So if they think they need to urinate and they go in there and they only pee for 5 seconds, you ask them, you know, is it a hard stream or is it just a trickle? Those are good questions. And if it is a hard stream, that is a sign of pelvic floor overactivity and detrusor overactivity. And then if it's just a trickle and it only lasts 5 seconds, then there's possibly a retention problem, or there could be a signal from the bladder going to the brain that they're full way before they really are. Your residual volume ultrasound would show that. Urologists do them every single visit usually. The stool leaking is important to capture with this. Like, is it truly a weak pelvic floor, or is there something else going on? This smearing with stools, I've seen a couple different like post-baby issues with the way they were sewed up and just having a little stool that gets caught in there. That can be treated with scar tissue mobilization and just trying to get that the sphincter to be able to move if they did have a cut through that and scar tissue. Or anal surgeries. I've had hemorrhoidectomy patients struggle with fecal incontinence afterwards because they have scar tissue and the inability of the muscle to contract fully. And then trouble emptying bowel and bladder. I covered that one extensively, I think. Anybody? Ask your patients if they have to strain to pee or poop. They should not have to strain to pee or poop. So what other specialties or practitioners have you seen for this problem? This can be a huge like open door into what's going on. Like maybe the patient's new to you and you're trying to get all of their history, and obviously you don't want to go into every single question about all of this, but have they seen a urologist? Do they see a urologist regularly? Are they under medications from a urologist? And then the stress levels or stress management recently. Pregnancy history is important. Urine leaking in a female who has had babies is not only a vaginal delivery problem. C-section mamas have leaking too. I attribute this to just scar tissue. Nothing, I mean, even, their scar tissue might even be connected to their bladder. They're sewed up and everything just heals how it is when it's healing. So that is huge. We, as pelvic floor physical therapists, we're going to mobilize scars. Like if they're C-section scars, episiotomy scars, a scoped scar from their gallbladder being removed. It's all just part of the story. And it's all trauma in the primal brain, and the pelvic floor is very primally related. So abdominal surgeries, hysterectomy, bladder sling, mesh, C-section, hernia. The most recent stat I saw, and I can't even quote where it came from, is 50% of people with multiple abdominal surgeries. So after their second abdominal surgery, 50% of those people, male and female, will end up with pelvic floor hyperactivity. So they might end up with that urgency or that frequency of urination because they can't have the abdominal movement correctly. Maybe there's scar tissue, maybe there's just trauma in there somewhere. But the closeness of that is definitely worth giving your time to explore. Oh, you've had 3 abdominal surgeries, did you bounce back well from those? Well, not really. Especially ones that didn't heal properly, didn't heal in the 2 to 4 weeks like the doctor said they would, if they had prolonged time out of work. All of that is going to generate into a possible like just pelvic floor holding and breath holding that they may not realize they're doing. Painful intercourse. Ask about this. This can definitely cue you into somebody who has a hypertonic pelvic floor. Both male with your erection or ejaculation, we usually distinguish between which one that causes them pain, or females just with either penetration, light or deep. And we even get into different positions and what muscles might be affected in those positions. So yeah, genital pain, or is it like hip or back, orthopedic, something, something's not sitting right, or is it something as far as the muscles might be too tight to perform the activity? Any questions about these questions? It's a lot, and y'all don't have to ask all of these questions. This is just ideas of, don't just give a patient a handout that says, here, do your Kegels because you have leaking. It is much more complicated than that, and if you want to kind of decide where you're going to put them down the path of treatment, you probably do have to ask some of these questions. Do they need to just go to gynecology? Do they need to go to urology? Do they need pelvic floor physical therapy? So I feel like these should be obvious, but let's go over them. You're always going to ask your female patient, when was their last vaginal exam with a gynecologist? There are patients, yes.
Or family physician.
Okay, when was their last vaginal exam, period?
By a board certified practitioner.
There you go. So So that's an important piece of information, and I like that family practitioners are comfortable with that, because a lot of women, after they have a hysterectomy, they think they don't have to go to a gynecologist anymore. Those parts are gone, I'm done with that. And that is not necessarily the case. There's other stuff that might be managed by a gynecologist. Menopause status, menstrual patterns, and then the hormone supplementation gets interesting. Everybody kind of has their own take on that. Onset and history of symptoms is obvious, like sudden onset of just like sharp abdominal pains. They probably need some sort of CT or something. Like, you're not gonna send them to pelvic floor PT and be like, okay, that pelvic floor PT can handle those sharp abdominal pains that happen 2 hours after you eat every time. So y'all know that. Discharge, quality, smell, other signs of infection, urine color, presence of blood, signs of dehydration. Those are all things that can be treated with education or medication, that are not necessarily a primary urinary incontinence issue. It could be that they're having incontinence because something else going on. Your pain gets complicated. So you have a patient who has low abdomen aching, painful intercourse, some aching afterwards, but sometimes aching with normal activities like standing for a while. Or you want to look for pattern with eating, of course. Like, is it something GI? Pattern with menstrual cycle. Is it hormonal? Back or hip pain being in connection with this is also a thing, because some of the nerves do wrap around. Deep ache, burning, stabbing, all things that might lead you to a more serious diagnosis. I call these the big nasties. So like, I trust my practitioners, either gynecological or family practice, to rule out these big nasties before they send me to a patient. Not that I'm not gonna see this and send somebody back. I have gotten referrals from primary care and immediately said, no, I need you to go see a gynecologist. This is something different. And ended up having cancer of the lining of the wall of your uterus. So there was just like this new onset, really weird kind of menstrual related thing that I was not comfortable with. She had concurrent back pain, and back pain is all she talked to her primary care doctor about. So that's where your clarifying questions come in. Okay, so pelvic floor PT. I feel like I've covered a lot of these things, but when I introduced myself as a pelvic floor PT, were y'all like, what is she gonna do for incontinence? Other than Kegels. My first, I'll call Michael out. I introduced myself to him and I said, I'm a pelvic floor physical therapist. He's like, oh, like Kegels? Hopefully you will not ever say that again. So pelvic floor PT, we are musculoskeletal experts. So I will draw your attention to this here. So these are, we went over the anatomy. You have layers and layers of skeletal muscle in the pelvic floor. Under voluntary control, can be trained, up-trained, down-trained. Let's say somebody has hip pain. We're gonna test and see, an orthopedic therapist, not even a pelvic health therapist, you're gonna test and see what's tight and stretch what's tight and see what's weak and strengthen what's weak. It's a lot of the same concepts, and that is why we kind of fall into this so easily in our level of understanding. We also have the neuromuscular component of, like, the nervous system drives everything, whether it's driving it up or driving it down. The nervous system is kind of your into the muscular system as well. You'll see some PTs that specialize in athletic performance, and that's just, we actually use the nervous system in an athletic performance evaluation, where your personal trainers and stuff is gonna just like, oh, make the muscle stronger, do more weight, do more reps, and we're definitely gonna take a different approach to it as far as looking at the body as a whole, and strengthening what's weak and stretching what's tight. So I explain to patients the pelvic floor is for bowel, bladder, sexual function, and organ support, and your core. So you will see so many people who have core weakness also have pelvic floor weakness, because it is all connected. You have somebody who has back pain, you send them to a regular physical therapist and they do all this core training, and that physical therapist may never address what's going on in pelvic floor. So that's also one of my plights, is I teach continuing ed for physical therapists, for them to recognize issues with pelvic floor and get a patient a specialist. Because sometimes they might be up training and core training and stabilization training, and the back just needs stabilization, and they're actually driving the urinary problems by tightening everything up. then that person's in the urologist's office, and the urologist doesn't even know they have back pain, and they're going to physical therapy, and the urologist treats them with overactive bladder medications, and then they have issues with swelling, and then they have, so that's an easy way to I teach the physical therapists is that's how you get into the patient being receptive to asking these questions. Y'all don't have that issue, I don't think. I mean, asking about bladder and bowel is normal for y'all, but us, when we're seeing a patient for back pain, if we start going, well, do you pee on yourself? They might not trust us very much. So that is important, that I just kind of say it's like a bowl, it does all these things, and it supports the hips and back. This is a cool way to get into how it's connected as well. So I see so many people with pelvic floor, both urge incontinence or urgency without incontinence, and your pelvic floor weakness and stress that has a hip problem. Their hip is weak, whatever reason, a history of an injury when they were 12. Or maybe today I evaluated a patient, she always carries her child on her left hip. So she has a scoliosis. He's 18 months old. She literally has a scoliosis where everything is tightened on this side and everything is lengthened on this side. And this hip is weak and this hip is tight and tender and strong. So guess what? She has pelvic floor problems. Because these muscles on her right side were insufficient. I call them the deep rotators. They're kind of all bundled in. Everybody knows piriformis for some reason. They don't know these others. Piriformis is going to be overactive if these others are not doing their job. Well, guess what? Piriformis runs right in line with the deep pelvic floor muscles, and so does obturator internus. Obturator internus is both a pelvic floor muscle and a hip muscle. So if it can't do its job, if it's trying to help the hip, it can't do its job as a pelvic floor muscle. So you're going to either get weakness or tightness of the other stuff trying to make up for the insufficiencies of those muscles helping the hip be stable. So everyone who comes into my clinic for pelvic floor problems gets hip strengthening as well. They get a hip evaluation, and obviously I pick what I'm going to strengthen based on that evaluation, but strengthening is a huge component of all of the other things too. The abdominal wall, their pressure control system. We'll go into this. So the core is like a balloon. You have the pelvic floor and the diaphragm, and then the abdominal wall and multifida on the back. If you have an insufficiency in any of these, you're going to lose pressure in that area. So diastasis recti or a hernia, abdominal hernia, bulging, pelvic floor, losing urine there. If you put pressure on one and the others aren't all turning on at the right time to support everything else, then that's going to lead to insufficiencies. And that's why we also have to address their breathing mechanics as well. Any questions about the pelvic floor is part of the core? The diaphragm is part of the core? The Kegel. So I started with not always the answer. So you will not believe how many people come into pelvic floor physical therapy and they're like, I've been doing my Kegels, I promise, I've been doing my Kegels, I still pee on myself. And I will go to do an exam and feel their Kegel, and they will be doing everything but a Kegel. They will be doing their thigh squeezing, butt squeezing, they'll even be bearing down instead of doing the lift. So that's an important point. Don't just tell them, hey, do your Kegels, because they're not going to do it right. They might watch a video on the internet and get a little bit of more information on how to do it correctly, but so consider the layers. I actually teach patient an elevator Kegel, so a light, a medium, and a strong. And then their ability to also relax in 3 levels is important too. Compensatory muscle contractions, I talked about that, inner thighs go together, butt squeezes, like everything. And then we also teach anterior versus posterior muscle activation. So there's different cues you can give a patient during the Kegel to get more of a urethral closing or an anal closing. The NAC is like the pelvic floor turning on at the right time. You cough, you sneeze. If it's a second too late, you're gonna leak. So that is just the coordination and the timing of the pelvic floor to lift before they cough or sneeze. That can be trained. It's not a huge difficulty to get somebody to start doing that. And the elevator squeeze I talked about with the layers. The contract and the relax is important. If somebody performs a Kegel and only relaxes halfway and tries to perform another Kegel, they're not going to get the benefit of the whole lengthening and contracting. So I always teach lengthening and contracting when I teach Kegels. Feedback, biofeedback used to be the standard of care. Put electrodes on beside their anus, give them a box or a computer screen, and tell them to do their Kegels, and they watch it go up and down. There are still some app devices now that provide biofeedback, and they can be very helpful for a person who is struggling with pelvic floor muscle weakness. And then there's actually direct stim to the area, and then my preference is actually palpating, either externally or vaginally, and feel what the muscles are doing. Are they contracting and lengthening? What's the timing like? Maybe they contract and then it takes them 5 whole seconds to actually get a full lengthening. Those type of people need down training. They don't know where the bottom is. They're probably halfway up all the time. And then tight pelvic floor. I feel like I've given this one a good bit of time, but you'll get your vulvodynia, painful intercourse, coccyx pain, interstitial cystitis, painful bladder syndrome. We're actually learning it's more of a pelvic floor condition than an actual bladder condition. Only about 10% of your people who get an IC diagnosis now actually have some sort of bladder lining issue on cystoscope. Your bowel disorders are also very connected with the hypertonic pelvic floor. Any questions about this part? I could do a whole nother lecture on tightness. This is cool for y'all. So hopefully you can see it. So step 1, somebody comes in, overactive bladder. Strong urges, sometimes leaks, sometimes doesn't. Always run into the bathroom, getting pants down as quickly as possible. Do you give them a medication? Do you send them to urology, or do you tell them to do their Kegels? You're gonna give them an overactive bladder medication. I thought that might be the answer. But step 1 is pelvic floor strengthening, bowel care. So if they're chronically constipated, they're probably gonna have chronic overactivity of the bladder. Dietary adjustments in your physical therapy. This is first line. Those things, educate, send to physical therapy, follow up in about 6 to 8 weeks. If things are not going well, happy with results, yes, good luck, see you in a year, see you at your next exam, whatever. Then this is kind of that, do your Kegels, educate on overactive bladder, that's your retraining cognitive behavior therapy. Urge suppression, we don't teach urge suppression right away, but urge suppression is a huge part of this mind over bladder. It's kind of how I teach it. Got you laugh. So then consider trying medication at that point. They've been educated, they've had their physical therapy, their bowels are doing better, they're pooping 5 times a week maybe. And then medication, give it a couple of months to work. If that's not working, try another medication. And then cystoscope, urodynamics, those types of treatments. And then they have Botox listed on there too. So medications, Dr. Motley wanted me to kind of cover this. So treat the urinalysis if it's positive. They have frequency and urgency because they have an infection. No big deal. Treat it, follow up though. Make sure that really was what was going on and their symptoms do resolve once the infection is resolved. Your anticholinergics is going to kind of calm down the system. That's usually treating overactive bladder. They're always on edge. That might be the only problem going on. Anticholinergics are going to be your kind of first line. They have side effects though, so make sure the patient is aware of that and it comes back to you with that. If that's a thing, don't let them think they just have to deal with the side effects. Supplements, your Azo line is pretty good for bladder stuff. There's some herbals out there that claim to help with bladder continence. I think they probably just calm down irritation and decrease strong urges, that kind of thing. Fiber and magnesium are big things that I recommend for people who have pelvic floor issues in general, because it is so connected to bowels sometimes, or just overactivity of the muscle. I feel very strongly that even though a lot of people are normal in their magnesium levels on CBC, a lot of people are deficient. They don't have enough. And magnesium is responsible for relaxation. So they're not sleeping well. That's in a cycle of everything's stressful, and just maybe there's a natural way to get them out of that. And then I have to definitely treat hormone deficiencies if that's part of the story. Vaginal muscle atrophy is a real thing in estrogen deficient patients or testosterone deficient patients. Myrbetriq and Elmeron. Elmeron is the only bladder medication FDA approved for true bladder irritation, but they're seeing all kinds of vision loss lawsuits and stuff like that, so I would just probably stay away from that one. And the clinical trial was 12 people and only 3 of them were better. Yeah, and it's still a medication and it's thousands and thousands of dollars. Oh, side effects, hair loss, diarrhea, nausea. I love reading side effects, y'all. So your myometric, increased blood pressure, common cold symptoms, dry mouth, flu, urinary tract infection, back pain, disease, joint pain, headache, constipation, sinus. This is the one that all the urologists are prescribing. All of my patients are on this. And I have so many of them that have fluid retention. They're coming in with swollen feet. I'm like, what is up with your feet swelling? They're like, I don't know. I'm like, did it happen before you took this medicine? No, not yet. So urology referral is not outside thing. I'm not saying send everything to physical therapy for sure. They're gonna do urinalysis, residual volume ultrasound, cystoscope. They're gonna kind of go down that same pathway. But not all urologists are sending to pelvic floor physical therapy, so you might be the person that steps in and helps that patient actually get at all the factors that are aggravating their bladder issues. Kegel trainers, vaginal weights. Pacey cuff is a penile clamp. It actually, for a male with incontinence, it literally closes the urethra. Impressa is like a tampon. It also literally closes the urethra, and there's pessaries for support of prolapse, and Uresta is an insert. Bladder Botox. Percutaneous tibial nerve stimulation is growing in popularity since the bladder has the same innervation as the tibial nerve. You can stim the tibial nerve and it will calm down bladder overactivity. It's a huge protocol to follow. It's not that easy to perform. It's just time consuming and insurance doesn't cover it. Correction of prolapse. Implants is a new cool thing. Talking to a couple urogynecologists, they love InterStim and Axonics. They think that they help a lot of people. I've seen a lot of people have issues with them down the road, especially even orthopedically. Like the pack is in the place and their hip is twisted because they can't put pressure on the pack. And BTL Emsella is this chair that you get to go sit on. You can pay money to go sit on this chair and it does your Kegels for you. It's a magnet. It's a magnet. It uses magnetic force to. Okay, so yeah, so you sit on it with clothing. Doctor, I'll remember her name in a second. But I walked into her office and she made me sit on that chair. We call it the vagina zapper. It works. You literally sit on a chair and it sounds like an MRI machine and it tingles and it's contracting. So if your patient doesn't want to do their Kegels, you can refer them to. The Mona Lisa is vaginal rejuvenation that some women feel like help their issues, and the medications we talked about. These are a few resources I want y'all to have.
What is vaginal rejuvenation?
Mona Lisa, it's a laser treatment for the vagina. It's 3 treatments, and it's basically just removing dead skin cells and rejuvenate, using the body's natural healing to reproduce fresh tissue that should be more pliable and work better. I love it, young nerd. We joke about things like that. Well, we joke about the weights too, but some people do benefit from vaginal weights.
Because any laser is going to create scar tissue. So removing that skin, is it going to make it worse down the line?
The people who sell it well. They sell it well. Same thing with the vagina zapper. Like people pay hundreds of dollars. So the Mona Lisa treatment is $1,000 a treatment, and it takes 3 to see your best results.
Sounds great.
Physical therapy costs about $80 a visit.
Yeah, that sounds way cool.
You can get a lot of physical therapy before you go get that. Okay, so this is like my quote for y'all. As medical professionals, we need to ask our patients about pelvic floor issues. Research clearly shows that if we do not ask directly about these problems, they're likely too embarrassed to tell us. Then we need to listen and provide a real solution, not just give them a brochure to do their Kegels. It's kind of my take-home message. I am on Facebook. You can follow me. I do Monday educational moments. Most of them are about pelvic floor lately, but I've been doing them for quite a while. Your Cosine screening tool It's fairly self-explanatory, but if you have any questions about it, reach out to me. You'll all have my cell phone number on that card. Pelvicrehab.com. I know y'all will all disperse at some point and be in different places and not here. If you're here, I'm it. I'm the only pelvic floor physical therapist. But when you disperse, pelvicrehab.com is where you can check, and it searches all of the database of pelvic floor physical therapists. I do also want to tell y'all, get to know a physical therapist. Like, even if it's not a pelvic health physical therapist, when you find your permanent location, find someone and know that they're providing good quality physical therapy. Just like every profession out there, there are good and there are bad, and there are PT mills out there, and there are so many people that said, I have tried PT and PT does not work, and it is because they did not go to the right PT. So find someone you trust, even if you have to seek them out. Make sure that they spend time with their patients. They don't just hand them off to some tech and do your exercises, and that's huge. So if you're an Instagram person, the Vagina Whisperer, that's where this quote came from. She posts lots of good stuff. She has a practice in New Orleans. Y'all, this is my life. Tea, food, and sex all day long. American Urological Association guidelines, the pelvic floor PT is grade A evidence. It's the only grade A evidence for painful bladder issues. And I think that's it. I had a really cool thing where y'all could type your questions on your computer, but not all on the computer. But let's talk. What are y'all thinking?
So do you see like the S-Trace vaginal cream? Do you see good effects from that for stress, incontinence?
Everything. Painful intercourse, stress incontinence. Yeah, it's just so controversial now because there's estrogen-driven cancers, and so the bioidentical vaginal estrogen cream is what I usually see the doctors recommending filing. But the other part of that, so the estrogen-driven stuff, but it is systemic, like, and patient compliance. That might be what they need, but patients just don't like putting creams in their vagina for some reason, like, so they won't be compliant, even if it helps them.
They do. You have to wear a lining and a pillow.
Yeah.
Injecting stuff is gonna fall out unless you're in bed all day doing
Yeah.
it.
Exactly. So they don't like the way it feels. They don't like it. They just. So ask the patient what they want. Do you want a vaginal cream? Do you want a pill? Do you want, pellets? The vagina zapper. There are patients
You need the
that
vagina
want the vagina zapper.
That sounds like a stimulant, I don't know,
It's called BTL Imcella. I actually brought the brochure.
Thank you. I gotta.
You're welcome. I know. I saw the time. I was like, oh man, I'm gonna hurry up. Those last few slides.
I'm so glad you ended with this part because you would have been distracted at the beginning.
Yeah, the vagina zapper was my last line, wasn't it? So,
You turn it is start from 100 and then ask for that section. You also need a receipt.
I knew as soon as it went to game 7, like, they're done.
But yeah, if y'all are Facebook people, follow me on Facebook, and y'all have my cell phone number. You can text or call me if you have any questions. Thank you. You're welcome. I enjoyed it. Thank you. You're welcome. Y'all have a good afternoon.
So that's not what you do full time though, pelvic floor. You do like everything.
Ha ha ha! I am doing it full time now.
Oh, are you? Okay.
Yep.
All right. That keeps you busy.
I'm not there yet since I just opened Monday, but
Okay.
I do have 3 patients this
We
afternoon.
will get you there.
Yes, thank you. I appreciate it. Your attendings have referral pads, and there's some referral pads here too.